Okay, guys, can y'all hear me? No. Put it closer. Okay, we're going to get started. For the students, my name is Ashley Marcantel. I'm one of the fourth-year residents, and we're going to talk today about endometriosis. So I'll review a few objectives that we're going to go over. We're going to review the etiology and pathogenesis of endo, the locations of endometriosis implants, and the coinciding images that you'll see, and review the diagnosis of endometriosis. We're also going to discuss treatment options, including existing and new novel therapies, and discuss surgical options for patients. What I'm not going to talk about is more of the fertility and infertility side of endometriosis, because it's a whole nother ballpark and a whole nother lecture. Okay, so we'll start with what is endometriosis. So basically, it's the presence of endometrial glands and stroma outside of the normal location. These implants are typically located in the pelvis, but they can occur at multiple sites, including the ovaries, the rectovaginal septum, ureter, bladder, bowel, diaphragm, pericardium, pleural cavity, vagina, all over. This disease causes chronic pelvic pain, causes dysmenorrhea, dyspareunia, and infertility. And it can be anywhere from minimal disease to severely debilitating. And it can affect women at all ages and from anywhere from premenarche to reproductive years through even postmenopausal years. So first we'll talk about the incidence. The incidence of the disease is a little harder to quantify because of the variety and severity ranges that happen in these patients. This makes diagnosis very difficult. Some studies have suggested that the prevalence is between 1% and 7% in women undergoing a routine tubal ligation, but it's much more common in symptomatic patients. Patients who complain of pelvic pain have a 70% incidence of endometriosis, and it's about 50% seen in infertility patients. So depending on what group you're looking at, that makes much more of a difference. So we'll talk briefly about the etiology. There's four main theories that kind of go along with how we get endometriosis. The most common is the theory of retrograde menstruation. The endometrial cells flow backwards through the fallopian tubes into the peritoneal cavity during menses, and these reflux fragments adhere to the peritoneum and develop their own blood supply. That's the main theory, and that's the predominating one. However, there's other situations that we know it can't all come from retrograde menstruation, and that's where these other theories come from. Another theory is lymphatic or vascular spread. This theory exists because of the presence of endometriosis in unusual locations, such as the perineum or the groin, where that's the predominant way that we would think that it would spread. Another theory is coelomic metaplasia. And this is the parietal peritoneum undergoes metaplastic transformation to become endometrial tissue. And this theory is supported by patients who develop endometriosis in the absence of menstruation, such as pre-puberty endometriosis. And finally, the fourth theory is the induction theory. And this is thought that hormonal or biologic factors induce cellular differentiation into endometrial tissue. So we'll talk about risk factors. So factors that increase the risk of endometriosis is nulliparity, prolonged estrogen exposure, shorter menstrual cycles, less than 27 days, heavier menstrual cycles, obstruction of menstrual flow, lower BMI, white or Asian race, and high consumption of trans fats. On the contrary, very similar to these, factors that decrease the risk of endometriosis is multiparous patients, extended intervals of lactation, meaning they have decreased estrogen exposure, late menarche, same thing after age 14, race with African Americans or Hispanic, and high consumption of omega-3 fatty acids. Also, we know that it's familial just based on our experience in clinic. Although there's been no definite genetic inheritance patterns that have been identified, they have been looking at different genes that might be related to endometriosis in families. And we know that there's an increased incidence in first-degree relatives and it's thought to be polygenic or multifactorial. In one study, they saw that 5.9% of female siblings and 8.1% of mothers were affected. And they're more likely to have severe endometriosis with a first-degree relative, and that's 61% versus 24%, so it's pretty significant. If you have a first-degree relative, these patients are much more likely to have endometriosis. And the relative risk is 5.2 for sisters and 1.52 for cousins, and this was just in one study, that's all. So we'll talk about anatomic locations. I kind of already talked about the extent and widespread nature of this disease, but endometriosis can be found anywhere, certainly any site within the pelvis or the extrapelvic peritoneal surfaces. Most commonly, it's found on the ovary, the pelvic peritoneum, the cul-de-sac, and the uterosacral ligaments, and that's where we predominantly see these lesions. Less commonly, they can be seen at the rectovaginal septum, the ureter, the bladder, the pericardium, any surgical scars like a phalansteal, and even in the pleura. And these implants have been identified on all organs except the spleen in the body. So obviously, that's the predominant ones that I've mentioned, but anywhere is possible. And rare sites can have more unusual symptoms, and they're usually related to the menstrual cycle. So cyclic rectal bleeding with rectal implants, or potentially hemoptysis with menses with pleural lesions. So, if you hear something in a patient's history that triggers this might be cyclic, just keep in mind it could be endometriosis, although that is less likely. So we'll talk about the different types of lesions in endometriosis. There's superficial peritoneal lesions, deep infiltrating lesions, and ovarian lesions or endometriomas. So the superficial peritoneal lesions are the classic lesions of endometriosis. They are found on the peritoneal surface. They usually contain glands and stroma, but sometimes the glandular component is sparse in the tissue. It's sometimes just more fibrous tissue that you'll see. They can be obscured by inflammation and fibrosis, and histologic diagnosis because of these things can be a little bit more difficult to get. If you have a small biopsy and you only biopsy fibrosis, you're not going to get the actual glands and stroma that you need. So I'll just put some pictures of some of the different lesions that you'll see. Kind of labeled them for you, but yellow-brown ones, they can be clear. You can see a peritoneal defect, and there can be one deeper inside that defect that you'll see here. They can be kind of a bluish color, black, white, red. So all of these things, if you see an abnormal lesion like that, kind of keep in your mind this might be endometriosis. This one is an example of white endo next to the bowel. And this we can see in the first one, you can see there's typical black lesions that you'll see. In the second one, kind of those windows and a combined picture of scarring. And then the white lesions on the far right is the hypervascularity and the scarring that you'll see. Some pictures just to kind of show you more about endo. 2 chocolate cysts here in that first box. Red and purple raspberry spots here. You can see it here. Powder burn lesions, that dark grayish color, and then just normal. So that's the first type. The second type is this deeply infiltrating endometriosis. And this is a deeper, more extensive form of endometriosis lesions, and they often are the cause of the deep adhesions and the dyspareunia that we see in these patients. And this is defined as a solid endometriosis mass, which is situated greater than 5 millimeters deep to the peritoneum. That's just the definition of what deep infiltrating endometriosis is. It's found in the more muscular tissues, the rectum, the colon, the bladder, the ureters, and it can also be seen in the uterine ligaments and the vagina. So last, we'll talk about endometriomas. Ovarian endometriomas are a common manifestation of endometriosis that we see. And And in about 1/3 of cases, both ovaries are involved. And you'll usually have surface adhesions and fibrotic walls. And these are not your typical simple cysts. They look different. They're smooth-walled, dark brown ovarian cysts, and they're usually filled with like a thick chocolate fluid. And they can be unilocular or multilocular. And they're thought to be from an invagination of the ovarian cortex, and then you have menstrual debris that gets trapped in there. So some symptoms. So it's very variable. You're going to see patients that have almost no symptoms to severe symptoms, and it doesn't always correlate with what you'll see on laparoscopy. So some people are asymptomatic, like I told you about the difficulty of figuring out how many people actually have this disease. But most do present with chronic pelvic pain and infertility. So it can be cyclic or chronic pain. Sometimes it's not 100% sure where the pain is coming from. Sometimes we think that it's from pro-inflammatory cytokines and prostaglandins that are released by the implant into the fluid to cause irritation. And the pain may be related to the depth of invasion with those deeply infiltrating lesions. They may develop a sensory or a sympathetic nerve supply that goes to the implant, which causes excitability and pain. So that can be part of the kind of where the pain comes from. Another symptom is dysmenorrhea, and this precedes the menses by usually about 24 to 48 hours in these patients. And it is not as likely to respond to NSAIDs and OCPs in these patients. And it's usually more severe than just a primary dysmenorrhea in a patient who has endometriosis. And then deep infiltrating endometriosis correlates with the severity in these patients. And we also see dyspareunia. It's often from the rectovaginal septum or uterosacral ligament involvement. So when these people have this, they're more likely to have pain with intercourse. And during intercourse, what happens is there's tension on the ligaments, and that actually triggers the pain. And that may begin after years of pain-free intercourse. So it doesn't mean all of a sudden they start having pain that relates to their disease. It doesn't necessarily matter how much pain they're in as to how severe the disease is, which is kind of counterintuitive. They can have pain with urination, pain with defecation, and then they can have just chronic pelvic pain, not just cyclic pain. And that's a common symptom. Another one of the main symptoms is infertility. And the incidence of endometriosis in women with subfertility is 20 to 30%, so it's much higher in this population. And the more advanced stages correlate more strongly with infertility. The endometriosis impairs the normal oocyte pickup and transport due to the adhesions and kind of the distortion of the normal anatomy. And it can affect fertility even in mild disease. So mild disease doesn't mean you're free from infertility. Folliculogenesis may also be kind of impaired in these patients, and there could be some problems with implantation. And finally, there's some definite patients. Some patients have intestinal and ureteral obstructions, and these they might have small bowel involvement with their endometriosis, the cecum, the appendix, the colon. Those might all be involved, and it can be so severe that it might actually look like cancer. And treatment is often surgical in these patients, but can be treated if they don't have any obstruction, and that's what they would like. So we'll talk about diagnosis. The physical exam is one of the first things that we all do. And usually the disease is confined to the pelvis in most cases. And so, we look for something to trigger findings. And with the exceptions of if you see endometriosis within your episiotomy or your surgical scar, that's obviously not in the pelvis, and the episiotomy, not the surgical scar. And rarely you can see it spontaneously develop in other areas. And you might see the characteristic lesions on physical exam, such as the powder burn lesions, even in the vagina or the cervix, and they will be tender or bleed when you touch them. You're going to see a couple pictures here. You see the scar endometriosis. We've seen a couple around the last couple years. And than on the cervix. Another helpful tool is a bimanual exam. It can reveal anatomic abnormalities. You can feel the uterosacral ligaments for nodularities or tenderness, and that can trigger possibly lesions. You can also feel enlarged or cystic adnexal masses consistent with endometriomas, and the uterus sometimes is retroverted and scarred down, or very firm, fixed cul-de-sac. That can also mean deep scarring. And although we know all these findings are around, the exam actually is not that helpful in a lot of endometriosis patients. It's not very sensitive for detecting disease, between 36 and 90%, and not very specific. So, you can feel painful nodules in 43% of these deep infiltrating endometriosis patients. And in 91 women with chronic pelvic pain and endo on exam on diagnostic scope, their bimanual was normal in 47%. So 50% of the time we see it on surgery and we don't feel it. So nodularity is better palpated during the menses, which makes sense because those implants are a little bit more flourishing, and you'll be able to feel them more often in that patient. So, we can get some blood work. You want to rule out other causes of their pain. Specifically, I'll talk about just a second about CA-125. It's a general marker. It's not something that's specific to endometriosis. It's going to be a general marker for peritoneal inflammation. These people definitely have peritoneal inflammation, but that's not always the cause. So, it can be sensitive to indicate disease, but it's definitely not specific. And they've been looking for other markers to tell us more, about does this patient have endometriosis, but nothing's really panned out to help us. So we'll go to imaging. First, and our favorite, ultrasound. Transvaginal ultrasound tells us a lot about these patients, and the good thing about ultrasound is that you can do it fairly easily, and it's cheap, and doesn't cause patient radiation. So there's a lot of benefits to ultrasound that we like to use. And it is the mainstay in evaluating symptoms associated with endometriosis, like pelvic pain. And it is pretty accurate in detecting endometriomas specifically, and it can help us exclude other causes. But you can often miss smaller endometriotic plaques or nodules. As y'all have read ultrasounds, they don't often mention these things. And endometriomas can be diagnosed by ultrasound with adequate sensitivity if they're 20 millimeters or greater. So, a endometrioma that's so decent size, we can see for sure on ultrasound. And the sensitivity is between 60 to 90%, and specificity can be up to 100%. And these are cystic structures with low-level internal echoes. And it can also be the great mimicker because sometimes they don't look like that, and they can have septations, and they can have thicker walls, and uncharacteristic. So endometriosis likes to be a very difficult disease. So this is an ultrasound of an endometrioma, and as you can see, it shows the homogeneous echotexture of the cyst, the ground glass appearance, characteristic of an endometrioma. And this is a transabdominal ultrasound of bladder endometriosis. As you can see here, right there's like a little nodule protruding from the posterior wall of the bladder. And that's something that can definitely be seen in ultrasound, although these are not as common. Okay, so some more diagnosis imaging that we can use is a CT scan. We can use that. It's suggested especially for bowel endo. If you're suspecting somebody has bowel involvement, that can be very helpful. And also in thoracic endo. So if you think it's not the typical straight up endometriosis patient, CT might be something that you would consider. And MRI is pretty good too. So small nodules have been suggested to be seen more easily on MRI. And they certainly can see endometriomas and adhesions, but it is more costly. And it's more difficult and a little bit not quite as easy as the transvaginal ultrasound. And so for that reason, ultrasound is still better, but if there's a question, an MRI can also be obtained to kind of give you more information. It's also really good for rectosigmoid lesions and bladder. Okay, this is the CT scan of a patient with thoracic endo. And as you can see here, it's here during menstruation, and you can't see it at all during when they're not menstruating. So the point is, make sure you get the test coordinated with their cycles, or it's not really going to be as beneficial. So we just remember that. And here you can see on an MRI a lesion here that the uterus is scarred down. And this is the bladder, and you can see a bladder lesion here. And then here's kind of comparison, ultrasound and MRI. Obviously the MRI picture is pretty, but you can still find the lesion on ultrasound. And what's good is that it was identifiable on both. So the primary method for diagnosing endometriosis is diagnostic laparoscopy with biopsy of the sample of the lesion that you see. And of course, the findings are variable. They can be discrete lesions, they can be endometriomas or adhesions. You can see like white areas of scarring from endometriosis. They can be variable in color, which I've showed you. These dark lesions that you see are from the hemosiderin deposition from trapped menstrual debris, just like in the endometrioma. So that's why you see them be dark. And then the white or red lesions kind of correlate better with the histologic diagnosis. So if you see one that you want to grab, get the red or white lesions instead of the black lesions, because you're more likely to get a good tissue diagnosis. And I've said a bunch of times, but pain symptoms don't correlate with what we see on laparoscopy. And the definitive diagnosis requires the histologic confirmation, but the presumptive diagnosis is made in often cases just based on what you find on laparoscopy. So you might biopsy something and you don't get a good biopsy sample, but you know it's endo, and you treat them like it's endo. And this does result in a little bit of overdiagnosis because the histologic diagnosis requires endometrial glands and stroma found outside of the uterine cavity. And that's just the diagnosis, that the histology. And like I said, the biopsies may have an inadequate sample, or have only biopsied the scar, and you didn't get the glands and stroma, but we know that it's there. So staging of disease, this is more useful, when you see a patient, you've done a diagnostic scope, and you're kind of trying to classify, okay, where does this patient fall in stage of disease? And the ASRM kind of developed a classification system, but it doesn't predict pregnancy or infertility, and it doesn't really correlate with symptoms. So it's just more of a staging for reporting your operative findings more than anything. So stage 1, minimal disease, is described as having isolated implants with no adhesions. Stage 2 is mild, which the implants should be less than 5 centimeters in total and no adhesions. Stage 3 is multiple superficial and deep implants with ovarian adhesions or without. And then the stage 4 is severe. So multiple superficial and deep implants with an endometrioma and dense adhesions, that's stage 4. This is like a little picture to kind of show you what I just talked about as far as how much is involved, and kind of describing, especially like after a diagnostic scope, what kind of findings and terms we would use. So, and then the American Fertility Society has this classification table that breaks it down, and based on how many scoring numbers you get, you can get a stage score also, or you can just use the little picture to kind of guide you. So, just had to take a little break so you don't fall asleep on me. We'll talk about treatment. So this depends on the patient's symptoms, their severity, their goals of treatment, their location of their lesions, and if they want to continue with fertility. And that determines how you're going to approach the patients and what kind of treatment they're going to get. So there's this really great table that's found in our Williams Gynecology book that kind of goes over how you should progress to treat a patient that has endo. And we're going to talk about all of these things, but it starts with deciding if it's for pain or for infertility. And I'm not going to really, like I told you, I'm not going to really touch on this, but it does matter. That is a big difference between how we're going to approach these patients. And for minimal pain or perimenopausal, we can sometimes do expectant management. This is not going to be the patient who's moderate to severe pain, but maybe the patient who has some pain that might want to start here. Also, your options for mild pain would be NSAIDs, combined OCPs, Progestins, GnRH agonist trial, and if that pain persists, then you would go to laparoscopy, excision, ablation, lysis of adhesions, and so on. And then post-op, you would consider OCPs or GnRH agonists with ADVAC, danazol, and we'll talk all about these. So first, expectant management. So a guy named Sutton from the United Kingdom published a study looking at surgical management versus expectant management for endometriosis. And he recruited patients with a previous surgical diagnosis of endometriosis stage 1 to 3, and he sorted them into either laser therapy or expectant management. And the laser therapy received treatment with laparoscopy, and the expectant management just had a simple diagnostic scope. They suctioned out the fluid of the pouch of Douglas and closed them up. They watched them at 3 and 6 months for a pain assessment, and at 6 months, the expectant management group was offered a second look and have treatment at that point, a year, like 6 more months later. And so they had 63 people in this study and similar staging. And at 6 months, the 62.5% of people reported symptom improvement with the laser, and 22% reported improvement in the expectant group. And 24 patients had a second look, and 29% had disease. So 25% had disease regression, and 29% had disease progression. So it's interesting that 29% did worse and 29% did better, so it's about equal, and 42% remained unchanged. So even when you don't do anything, these people can get better and they can get worse. But you can expect a lower pregnancy rate after expectant management, of course, because we didn't do anything. And of course, they do not recommend this for severe endometriosis. It's not even considered in the trial. So next is NSAIDs. These are non-selective COX-1 and 2 inhibitors. They're the enzymes responsible for the synthesis of prostaglandins, and they're involved in our pain and inflammation. And the endometriotic tissue actually shown to express COX-2 at a greater level than the normal endometrial tissue. And so these work better for these patients for that reason. So they can often be a first-line therapy prior to a diagnostic scope, or in somebody who has minimal to moderate pain with known diagnosis. They do not help with disease regression. They're not going to make it go away. They just help the pain symptoms. And the problem with these are the cardiovascular risks associated with long-term use. So we try to use it for the lowest dose for the shortest duration. Combined OCPs is another option, and it's the mainstay for endometriosis treatment. And they have lots of benefits, and which is how they work. They inhibit gonadotropin release. They decrease the menstrual flow. They help visualize the implant. They reduce the actual nerve fibers and the growth factor expression that can cause the pain in the lesions. And they also help with suppressing ovulation and contraception. And often these patients, it's really good to use a continuous active pill or a Seasonique or something that doesn't have them menstruate as often. And that's going to help decrease the amount of painful menses that they have. Although, often we'll use monophasic, there's not really studies that show that monophasic is better versus triphasic, one versus the other. And low dose has not been shown to have any improved benefits over the conventional dosing, and it actually causes them to have more irregular bleeding. So normal dosing, continuous dosing is best. So next is progestins. Progestins antagonize the estrogenic effects of the endometrium. It causes decidualization, it causes atrophy of the endometrium, and it reduces the nerve fiber density, like COCPs, and the growth factor expression. So these are good for that. You know, we have oral, we have Depo-Provera, IUD, all different options. There was a study done by Telema, that showed 6 months of oral high-dose progesterone versus a placebo. And the second look laparoscopy, which they like to do in these studies, showed partial or total resolution of the implants in 60% and a significant reduction in pain. So that's interesting that these progestins at high doses can really help, but the key is high dose. These require significant amounts of progesterone, sometimes like 2 shots of Depo, or significant, you know, in this study, they used like 100 milligrams of progesterone daily, and that's just a ton, and these side effects are pretty significant. So they can get acne, edema, weight gain, irregular bleeding, which usually makes them not want to do it anymore. Like I said, so Depo-Provera actually can help reduce the pain and the amount of lesions, but you do get that adverse side effects, bad weight gain, edema, bone loss, and you're probably going to, you know, sometimes they'll need double the dose to achieve the pain, so you're going to get double the side effects. And then, you know, you have your norethindrone, the synthetic progestin that's shown to help with pelvic pain, and this is dosed at 5 milligrams per day, and you increase it until you get amenorrhea at a max dose of 20 milligrams, and you can see significant 90% reduction in dysmenorrhea and pelvic pain in these patients. And sometimes we can use these in conjunction with the GnRH agonists. So, another progesterone is Dienogest, and this is actually used in Europe and Japan and Australia. And it's a synthetic progestin that's actually more effective than the placebo at a small dose, which is just 2 milligrams per day. But unfortunately, we don't have it here, so we can't use it yet. But it might be something that might come out eventually. The Mirena IUD can also help show symptomatic improvement in up to 30 months in these patients. However, the continuation was only at 3 years was only 56% because these people had persistent pain, it wasn't enough help, and they still had irregular bleeding. And they said in one of the studies that looked at this versus a GnRH agonist, there was equivalent pain control to that GnRH agonist, but it doesn't help with bowel involvement. Another treatment is androgens. It was actually the first medical treatment approved for endometriosis, was Danazol, and it's kind of fallen out of favor due to its significant side effects. Side effects including acne, hot flashes, hirsutism, adverse lipid profiles, voice deepening, things like that. So Danazol is a synthetic androgen. It suppresses the LH surge and creates like a chronic anovulatory state. And it occupies the sites of the sex hormone binding globulin to increase free testosterone, and binds directly to the progesterone and androgen receptors. So we get this hypoestrogenic, hyperandrogenic state. And this helps create atrophy in those implants, which makes them feel better. And the dosage is 200 milligrams 3 times a day. And it does improve pain and disease after 6 months of use. But you have to use it for 6 months to see the improvement. So at this dosage, you'll see side effects. And some people don't really like this drug as much, since we've got some other ones that are available with less side effects. This one is similar to Danazol, but it's much better tolerated, but it is also not available in the United States yet. So it's called gestrinone, and it's an anti-progestational agent that's available in Europe, and it induces progesterone withdrawal. It decreases the number of receptors, and it does have a small amount of androgenic side effects, but not nearly as much as Danazol. And it's supposed to be equally effective as Danazol and Lupron. And in 6 months of treatment, it was not associated with bone loss like the GnRH agonists and effective in severe pain. So then there's GnRH agonists. And we know that the pulsatile release of the gonadotropins from the anterior pituitary stimulates steroidogenesis and ovulation, and this works by creating a non-pulsatile, consistent on switch, and that results in desensitization in the pituitary and then loss of this. You'll initially see a burst when you treat these patients. You'll get a burst of hormones, and then after a period of time, you get the desensitization. So you get the loss of estradiol production. You get a hypoestrogenic environment, and these people, it's what makes them hate this drug. And you get a pseudomenopausal state, and it reduces COX-2 levels in patients also, so that helps for the pain aspect. But it's not available inactive oral, so you have different options. You've got a Lupron depot shot monthly or 3 month, but there's also a couple others. There's a goserelin, triptorelin, and nafarelin. Nafarelin is a nasal spray. One of the big things about Depot-Lupron, I don't even know if we realize how much it is. It is extremely expensive. It costs like $1,000 every time we give that shot. And so if we're talking about other options, we might want to just keep that in the background, like how much is it costing us? But interestingly, nafarelin, the nasal spray, is actually $2,200 per bottle. So don't write that one. They're not going to get it. And, you know, they have this 11.25 3-month dose, and in private practice, per Dr. Betcher, he said he never would give that patient the 3-month dose first, because if they hated it, they were stuck with it for 3 months. So if he would at least give them like a couple trials of the 1 month before he committed to the 3-month shot, since it's so much more expensive. They can be used empirically prior to laparoscopy in pelvic pain, and after 3 months of use, you can see improvement in pain, and even greater at the 6-month mark. And this pain is equal to OCPs for pain relief, but it's more important in dyspareunia. This really works in those patients. So in GnRH agonists, you're going to have these patients that I've talked about that have hypoestrogenic states, and that kind of prevents us from using it for longer than 6 months unless we talk about add-back therapy. They'll get hot flashes, insomnia, reduced libido, dryness, headaches. We've seen these patients in our clinic. They have a lot of complaints when they take this medicine. And also there's a concern for bone mineral density. It's shown to have spine and hip was decreased at 3 and 6 months of therapy. So even with just 6 months of therapy, you can see decrease in their bone mineralization. And only partial recovery at 12 and 15 months. So you have to keep that in mind, especially in our young patients. We want to make sure that we're trying things that won't hurt them. And so that's why the limit is on the 6 months unless add-back therapy is included. You can use add-back therapy with estrogen to allow you to treat this patient longer than 6 months in these severe cases, but that's not going to be the first line that you think. You want to give them enough estrogen to prevent the bone loss, but not stimulate the endometrial growth. And there's not a general single threshold, but they say about 30 to 40 picograms per mil of estradiol should be sufficient. You can use norethindrone 5 milligrams a day plus the Premarin oral 0.625 daily for 12 months in these patients with the GnRH agonist, and that's one regimen that may work for us. And this has been shown to preserve bone density and provide an extended amount of pain relief beyond that 6-month window that we're treating them. There's other regimens, OCPs, transdermal estrogen, things like that, and you'll see lower bone loss in these patients that have the add-back therapy. And they say you can start it like right away when you do the Depot-Lupron, or you can wait, but there's really no benefit in waiting to start the add-back. So this is another one that's not yet approved. It's not even approved in Europe yet for endometriosis, but it's like on the horizon, is GnRH antagonists. they don't produce that initial flare that you see with the agonists, and so the suppression is immediate, and you can use the suppression for, it's already approved for premature ovulation in IVF, so it's already on the market, but it's not approved for endometriosis right now. But some studies have been starting to look at it to see if it will be something that we could be interested in using for endometriosis. And there's a drug called Cetrorelix, that's the one that's out in the literature right now, that they've been looking at to try as an alternative to Lupron. And 100% of people, which was 15 patients, saw improvement with 3 milligrams a week for 8 weeks treatment. They were nearly completely symptom-free during the treatment, and they did not have the estrogen withdrawal. So that's something that we could potentially be interested in the future. And their only side effect, they had a little bit of irregular bleeding. That was the only complaint. And then they did a second look laparoscopy, and they showed disease regression in 60%. So it does reduce symptoms, and it does reduce the disease. They don't have the long-term depot form available yet, and because it's only been used for IVF at this point. And it seems like it's not going to require add-back therapy. So something to keep, maybe 5-10 years down the line, we might be seeing this drug. Some other novel therapies that are out there that hold, promise for future treatment, but they're not FDA approved currently. They are approved in Europe, but they not yet here, is progesterone antagonists. They bind to the progesterone receptors and inactivate them. Mifepristone is an example, and reduces pelvic pain and the extent of endometriosis when it was used for 6 months at 50 milligrams a day. So this is something that, we're familiar with this drug. We don't really use it here currently, but it's on the horizon to be the next thing to treat endo, since it's approved for other uses. And then, of course, the selective progesterone receptor modulators are out there, and they're still in trials, but they're thought to potentially help induce endometrial atrophy and amenorrhea and improve pain. Aromatase inhibitors are an option. These, there's actually like a specific clinical opinion out about these uses in endometriosis patients. And the endometrial tissue produces the aromatase, the enzyme which is responsible for estrogen synthesis. And estrogen is produced locally in these implants, and they aromatize from androgens. And so this is actually targeting that specific action and helping to reduce estrogen production in those endometrial implants. And it's really good in postmenopausal endometriosis, which obviously is not that common, but it's apparently great for these patients. It causes significant pain relief and lesion size reduction, and may be used with add-back therapy for 6 months. In patients who had severe intractable pain, it really does work. Other potential therapies out there, they're actually looking at simvastatin to help exhibit an inhibitory effect on endometriosis in mice, so that's interesting. And then rosiglitazone, Avandia, is the insulin sensitizer that also has been looked at to possibly help in these patients with endo. So something coming. Finally, we'll talk about surgical treatment. This is the primary method of diagnosis, is at laparoscopy. So of course we're diagnosing them. We could treat them at the same time. It's great. So it's an attractive treatment option while you're already investigating what's going on. So there's some argument about ablation versus excision for which one works best. In the literature, it's not 100% clear as far as if there's any benefit to excision versus ablation, but our Dr. Betcher had really felt like the overall general consensus was that excision was better, although I didn't find any studies that specifically highlighted that point. We do know that ablation can reduce significantly reduce their symptoms. They see 63% relief versus 23% for just doing a scope. Now there's 23% who just felt better after we put a scope in. So, but 63% felt ablation was helpful. But recurrence is very common. There was a mean time of 73 months to recurrence, and 74% of people recurred. So, I mean, this is pretty significant. You're going to have these people come back. And it's unclear if taking down the adhesions really helps pain relief in the literature. So another surgical treatment would be endometrioma resection. The traditional treatment was either a total cystectomy or to aspirate and ablate the cyst capsule. And so Beretta did a study of 32 patients in each group that looked at drainage and coagulation versus complete cystectomy. And 32 patients were enrolled in this group, and they looked for about 24 months recurrence rates of pain, dysmenorrhea, dyspareunia, non-menstrual pain. And they found that they were actually lower in the cystectomy group versus the drainage and coagulation. So 10% versus 53%. So it can significantly help their pain if you actually remove the cyst rather than just draining it and ablating it. And these pregnancy rates were actually higher in the cystectomy group also. 15% of these are going to recur after 2 years, and they do decrease their fertility. So, removing a piece of the ovary can potentially decrease the ovarian reserve, so they can be watched. And they recommended a 6 to 12 week repeat ultrasound in those patients. So there's this other surgical pain control, which would be presacral neurectomy. Basically, they transect the presacral nerves that lie within the inner iliac triangle, and basically to help relieve pelvic pain. This is obviously not routinely recommended. This is like the very severe cases of refractory pelvic pain. It's also not helpful in any lateral pain. If you have lateral pain, this is not going to work. Only with midline pain. And they see greater relief at 12 months than ablation alone. So if you do this in addition to ablation. And it's apparently a very technically challenging surgery to perform. And of course, there's hysterectomy. So it's the definitive and most effective therapy in women who don't want to have babies anymore. But, we had this discussion with our younger women. Do we leave their ovaries? Do we take them out? If women forego a BSO and leave their ovaries, they have a 6-fold greater risk of recurrence of pelvic pain and an 8-fold greater risk of requiring surgery. And even with a hysterectomy and a BSO, they still are 10% will have recurrent symptoms, and almost 4% will need surgery. So, the key is to have the discussion with your patients as to, yes, if I leave your ovaries, we may be talking about surgery later. So depending on how she feels about that, and versus weighing the risks of premature ovarian loss and increasing heart disease and other complications. So, in patients who undergo a BSO, you want to think about postoperative hormone replacement, especially in younger women. These women typically undergo surgical menopause earlier, and so those people are better candidates for hormone replacement. And disease recurrence has been reported with estrogen replacement only. They did not recur with combined regimens. And as far as timing, when you start this is unclear. If you want to do a 6-week delay versus immediately after surgery, there's really no benefit one way or the other. And that's pretty much it. Does anybody have questions about endometriosis? I know it's a little dry.
I just have a couple comments. So when I went for my board review course, we had this other REI guy, and he had quite a few endo patients that he followed and put on GnRH agonists for years with add-back therapy. And so I think that it's something we don't really think about, but it's certainly something in the motivated patients who the GnRH agonists work. They can be kept on it for years as long as you have them on the add-back therapy. And he had a lot of young college-age students. Most of our patients are wanting surgery, so they aren't really the type of motivated patient. But when y'all get out in private practice, that's definitely something. And he just would follow them with like DEXA scans and stuff to make sure they weren't having any bone loss. And the other thing is when you're counseling them about surgery, sometimes If they have issues about whether they want their ovaries done or not, sometimes it can be beneficial to go in and do a diagnostic scope, because you don't know what kind of stuff is going on in their pelvis, and so to counsel them better, because they have a risk of having surgery regardless of whether you take them out or not. But if their pelvis is a bomb, you take out that uterus and try to go back in later and take out those ovaries, it's going to be a disaster. And so sometimes, even if they may want to keep their ovaries, it may be worth it to take it out just because of future surgical issues. And so if you go in with a diagnostic scope that's quick and easy, you can better counsel your patient after that as to what kind of surgery they really need. So it doesn't usually hurt to do a quick diagnostic scope, so you have a better idea of what you're talking to your patients about. Unfortunately, most of our endo patients really aren't that impressive, so I don't know if Dr. Vandermolen's gotten a lot lately, but you see some really bad ones. But generally, we do diagnostic scopes and you don't see anything. So
they're in that mild disease and severe pain category.
Yeah, we get a little jaded here.
Well, we unfortunately see a lot of really bad ones that are in the bladder and the rectum, have multiple loops of bowel. This is a heinous disease. I can tell you right now, the two most complicated surgeries I've ever done have been extensive endometriosis. It has no respect for peritoneal planes. It goes transperitoneally. It'll go into any organ. And the inflammation is caused, especially in a reproductive age patient, with every cycle, and bleed and scar and bleed and scar and bleed and scar is horrific. If you get to doing 2 or 3 surgeries on these people, I'd certainly advise you to contact your local friendly gynecologic oncologist to be available, because we wind up doing hours and hours of bowel resections and bladder reconstructions and renal. I've had 3 cases where the endometriosis in both side walls had completely transected ureters. I mean, you dissect them down to free them because they're dilated and come to a point where there's no more ureter there, and it's completely obstructed, so you have to do reimplantation. If you're going to leave an ovary in, people want that a lot. We always recommend trying to suspend them so they're up out of the pelvis. At least you know where it is when you go back in, number 1. Number 2, you may not be as creating much additional inflammation and scarring and things in the bowel that's deep in the pelvis. It's harder to get to. You've got to go back in.
Thank y'all so much.